I changes the HIPAA risk picture. PHI can leak through prompts, training data, model outputs, logs, or unsafe clinical advice. In this section, we'll turn those risks into practical safeguards, monitoring, policies, and audit-ready evidence. We've already built the map: AI systems, data flows, PHI touchpoints, and the HIPAA safeguards that apply. Now we'll use that map to evaluate common AI risk scenarios, including prompt leakage, memorization, sensitive training data, and medical advice, before moving into incident response and breach notification. AI risk becomes manageable when it is framed as a scenario, not a vague concern. Start with the source, a prompt, training dataset, model response, log, integration, or user action. Then connect it to a HIPAA impact, such as disclosure, misuse, access failure, or weak auditability. From there, choose controls that prevent, detect, or correct the issue, and preserve the evidence in the risk register and control matrix. That trail makes mitigation defensible and auditable. Consider a clinician using an AI tool to summarize a visit note. If the prompt includes the patient's name, MRN, diagnosis, medication, and lab results, that PHI may pass into logs, third-party services, or training pipelines. The control is not never use AI. It is to minimize PHI, use approved endpoints, and enforce strict retention rules. Prompt filtering works like a safety checkpoint before the AI sees the request. The system scans for PHI, such as names, dates, medical record numbers, contact details, and clinical context. Policy then determines what happens next: block high-risk content, mask identifiers, warn the user, or route the request for approval. These controls should apply across chat, APIs, browsers, and endpoints, with audit logs that capture decisions without storing unnecessary PHI. Minimum necessary prompting begins with a simple question: what does the AI actually need to know? Direct identifiers such as names, dates of birth, addresses, and record numbers should be removed unless the approved task truly requires them. Replace specifics with placeholders and use structured templates that capture only relevant symptoms, medications, vitals, or operational facts. The practical test is this: after redaction, can the AI still produce accurate, safe, useful output without unnecessary PHI? AI logs are useful, but they can quietly become PHI repositories. Treat prompt activity like any other sensitive record. Capture only what is truly needed, and avoid storing raw prompts or responses by default. Protect logs with encryption, limited admin access, and audit trails. Separate usage metrics from PHI whenever possible. Set a retention period, and delete data when that period expires. Before using external AI tools, confirm vendor logging, retention, and training settings. Strong prompt governance starts before a user submits data. A just-in-time warning can prevent accidental PHI disclosure and remind staff which tools are approved. Policies define acceptable use, prohibited tools, and when to escalate questions. Training makes those rules practical. Use the minimum necessary information, avoid identifiers unless authorized, and treat AI outputs as sensitive. Acknowledgements then create accountability for employees, contractors, and anyone else using AI in the workflow. A model can sometimes act less like a learner and more like an echo. If training data includes rare cases, repeated notes, or direct identifiers, the system may reproduce fragments later. In healthcare, even partial details can identify a patient. Protection starts before training. Minimize the data, de-identify carefully, test for leakage, and monitor outputs after deployment. Before health data becomes training data, ask whether identifiable PHI is needed at all. Inventory the fields, then assess identifiability using safe harbor or expert determination. Remove or transform direct identifiers, rare combinations, free text clues, and irrelevant attributes. Then confirm that the remaining data still supports model performance and validation. Document the choices, dataset lineage, and residual risk, so privacy protection is traceable, not assumed. Mitigation is not complete until you try to make the model fail. Use targeted adversarial prompts to see whether it can reproduce patient names, dates, identifiers, rare cases, or verbatim training text. Scan generated outputs for PHI patterns and unusual clinical details. Repeat these tests before release, after fine-tuning, and during monitoring. The results become risk evidence, driving fixes, severity ratings, and HIPAA governance documentation. Fine-tuning with clinical data should follow a gated path, not an informal experiment. The dataset and purpose need explicit approval. Training should occur only in a secure, isolated environment with encryption, access controls, and version data. Reuse for unrelated work should be blocked. Before deployment, evaluate and document the model, including its data sources, intended use, restrictions, and results. That record becomes the control point for ongoing oversight. In healthcare, risk increases when AI sounds more certain than it really is. A chatbot that suggests a diagnosis or treatment may be mistaken for clinical advice, especially without review. The control point is clarity. Define the tool's scope, require clinician oversight for clinical decisions, monitor unsafe outputs, and escalate anything that could affect patient safety or HIPAA obligations. Clinical safety is not one control, it is a chain. First, define what the AI can and cannot do, with clear disclaimers that it is not a clinician. Next, validate outputs against approved clinical references and safety rules. For diagnosis, treatment, medication, or triage, require qualified human review. Finally, monitor incidents, feedback, near misses, and recurring defects, and escalate urgent symptoms to licensed professionals. The main lesson is readiness. Protect prompts with filtering, redaction, DLP, secure logging, and policy. Reduce training data risk through de-identification, minimization, controlled fine-tuning, and leakage testing. Keep AI clinical outputs bounded, reviewed, validated, and monitored. Next, we turn these controls into incident response and breach notification.